Hello and welcome to today's session on skin tear assessment and management. I'm Jen Letchford, I'm Tissue Viability Nurse Advisor with Coloplast. The learning objectives for today's session are to understand the anatomy and physiology of the skin, to recognise some of the red flags associated with skin tears, to be able to identify different types of skin tears, whether that be type 1, 2 or 3. How can we best cleanse and dress skin tears and help to manage those skin tears moving forward? So the skin and its function. The skin is the largest organ in the body and it has three key areas that we're going to be thinking about today: the epidermis, the dermis and the subcutaneous layer. The skin is the main protective function and barrier in the body against microorganisms, toxins and UV light. It helps to protect the internal organs, helps to regulate temperature, and also produces the secretion of sweat. When we start to age, our skin becomes more vulnerable, and that can cause a thinning and flattening of the epidermis, a reduction in the collagen and elastin, dryness due to the reduction in sebaceous and sweat gland activity, and puts us at higher risk of fragile skin, which could lead to an increased risk of skin tears or slow to heal wounds. So a definition of a skin tear. A skin tear is a traumatic wound caused by mechanical force, including removal of adhesives. The severity may vary by depth, but will not go through that subcutaneous layer. So we need to be thinking about how these occur, what sorts of things can cause them. We need to try and remove any of those potential causes to try and prevent rather than have to treat these skin tears. We face lots of challenges in wound care, and looking at community nursing numbers and district nursing numbers, we've seen a real decrease in staffing numbers since 2009. And I know from my own experience working in the community, both as a district nurse, community nurse and tissue viability nurse, that I've seen lots of staff leave or retire, and it's really difficult to get new staff into the community setting. So we've seen that reduction in staffing, we've seen an increase in wound prevalence. Looking at our patients and patient demographic, we've seen an increase in elderly patients. People living with comorbidities, putting them at higher risk of skin tears. And then more recently, COVID-19 and the impact that has had on all of us within the health economy. So what causes a skin tear? Can be a result of a knock, a trauma, bump, friction and shearing. It's a partial or full separation of the outer layers of the skin. They can be perceived as minor injuries and quite often are perceived as minor injuries, but actually if they're not treated appropriately from the start, then they can become complicated, infected and actually quite complex wounds to try and manage. They can occur on any part of the body, but we're more likely to see them on the extremities, so the backs of hands, feet, lower limbs and arms. Who's at risk and what puts us at higher risk? Well, if we look at general health, it could be somebody with critical illness, chronic illness, somebody that takes lots of different medications, so polypharmacy, someone with an impairment, cognitive, sensory, or auditory, someone with a nutritional deficit, not getting that nutritional intake, somebody who's dehydrated, all of these things can put somebody at higher risk. Mobility. Does the person have a history of falls? Do they have impaired mobility? Are they completely independent with their activities of daily living, or do they require support? We need to be thinking here about our potential wheelchair users, for example. Are they able to manoeuvre themselves appropriately without causing any potential trauma in doing so? Skin, the extremities of age, those very young in the first few days of life, first year or so of life, and those at the opposite end of the scale with that fragile skin, aging skin. Someone who's got a history of skin tears, you know, why have they got that history of skin tears? Is it because they keep having falls linked to mobility? So we need to be building a picture and looking at whether our patients really are at risk, and completing these sort of risk assessments as part of our holistic assessment. The same with anything. Prevention is better than cure, and the application of emollients can really help keep the skin supple and reduce that risk of a break, and that reduce the risk of trauma. Protective gloves should be worn when necessary, when touching or treating a patient. We also need to keep short nails, not wear jewellery. For those of you in the NHS, you'll probably be aware that you're meant to have short nails not only to help with infection and prevention control, but also to prevent us from catching the patient's skin and causing a trauma wound. The jewellery is a similar situation. So if we're wearing rings with stones in and we catch that across somebody's skin who has that fragile tissue paper-like skin, we're more likely to cause an injury to somebody. So we want to try and prevent that as much as possible. Does the person use a wheelchair? Do they need padding on their wheelchair to prevent any trauma wounds to their hands if they're trying to wheel themselves, for example? Do they have bed rails or furniture that they're likely to catch themselves on? I don't know about you, but hip height tends to be the same height as my desk at home, and I'm forever catching myself. If I had fragile skin, then potentially that could be a risk for developing a skin tear in that area. So they're all things that we need to be aware of. Correct handling, manual handling techniques. Are we using slide sheets when it's appropriate to do so? Do we know how to use those slide sheets or hoists and hoist slings? So making sure that we're using the correct technique to reduce any risk of causing a skin tear. If somebody is at higher risk and we know that they have fragile skin, are we encouraging them to wear long trousers, for example, instead of having their legs exposed and lower limbs exposed? Do they need padded garments, padded or protective footwear to try and prevent a trauma wound or injury? Are they well nourished and hydrated? If we have somebody who's dehydrated, their skin will also be dehydrated, which again puts them at a higher risk of developing a skin tear. Environmental awareness is key. Do we have trip hazards? Are there things that need to be removed? If you're not sure, then maybe you want to refer to your occupational therapy team, for example, for their input and support. Trying to prevent these wounds from happening and prevent these potential falls, which skin tears are quite often linked with, will help overall to reduce the number of skin tears that we are trying to manage. We want to try and maintain the skin integrity, which could include using a protective dressing. Not always do we want to cover areas unnecessarily, but if we have highlighted that there is an area that's at very high risk and could do with some padding or protection, then we may want to do that. That will depend on the individual and should be assessed on an individual basis. So the International Skin Tear Advisory Panel, ISTAP, have produced this decision algorithm to try and help us with managing skin tears. And what we initially need to do is to assess this skin tear and control any bleeding. We would then want to cleanse this wound and approximate the wound edges where we're able to do so. It's at this point that we would also classify, measure and document this wound. We would then be looking at identifying the treatment goals and how we can best treat this wound moving forward. So there are different types of skin tear, type 1, type 2 and type 3, which we're going to look at in slightly more detail. So type 1 is no skin loss. It's that linear or flap tear which can be repositioned to cover the wound bed and is likely to heal fairly quickly. Type 2 is where we have a partial flap loss. It can't be repositioned completely to cover the wound bed, so we do have some of the wound bed exposed. It's likely to take slightly longer to heal than that of a type 1. Then we move on to type 3, and it's that total flap loss, where we've lost that top layer of skin completely. It will be an exposed wound bed, and we need to look at how we best manage that wound bed in order to prevent infection and promote an optimum healing environment. So dressings as treatment should be easy to apply. They should provide a protective anti-shear barrier. We want them to optimize that healing environment, as I spoke about in the last slide, and create that balance of moisture and bacterial load, as well as create an optimum healing temperature and pH balance. It needs to be something that's going to be flexible and mould to the contours of the skin and to the wound bed where possible. It needs to provide that secure but not aggressive adhesion and retention. So we don't want it to cause more trauma on removal. When a dressing doesn't fit perfectly, a gap can form underneath it. And certainly when we're looking at skin tears, we quite often see that they're superficial wounds, or they're normally described as superficial skin loss, which isn't wrong, but actually it does still allow for a gap to form. So when I talk about the gap, I mean the gap between the wound bed and the dressing that we're applying. And if that gap is allowed to form, it can lead to exudate pooling. And if exudate then leaks onto the edge of the wound or peri-wound skin, it can become macerated and delay healing further. The pools of exudate may also lead to bacterial growth and increased risk of infection. So by having a wound dressing that conforms to the wound bed, it prevents the gap from forming and prevents that cascade of challenges that we may then experience if we don't manage that gap effectively. So the type of dressing I'm talking about here is biotain silicone or biotain silicone light with 3D fit technology. They will absorb vertically, so they'll protect the surrounding skin from any maceration or any damage to the wound edges. It will conform to the wound bed of up to 2 centimeters in depth, meaning that you don't need a primary dressing underneath. You don't need to be using any sort of filler. It will conform down into the wound bed and create an intimate contact with the wound bed. So if we have an irregular wound bed, then it will manage that for us. It also retains exudate and 99.98% of bacteria, which will help to reduce any risk of peri-wound skin damage, as well as reducing the risk of the development of an infection. When we look at the development of infection or the things that again would increase risk of that, we need to be thinking about how we're applying these dressings. And really we should be using an aseptic non-touch technique, which I'm sure you're all familiar with. But we want to try and prevent any wound infection and promote timely wound healing. So we need to be cleansing our hands, using alcohol gel, using a preparation surface or a clean preparation area according to our local policy. And we want to make sure that we have the right equipment with us to be able to dress these wounds. That could be sterile gloves, gauze, some saline, the biotain silicone or biotain silicone light, and we may want to use the disposable tweezers if we have those in our packs. If not, then we would wanting to be reapproximating the wound either with a moistened piece of gauze or potentially our finger in a sterile glove. So various ways that we can do this, but I would have a look at your local policy and local procedures to see how you're best to do that in your area. We then look at dressing application, and we want to be placing the dressing on the wound, removing the central release liners from the dressing, from the biotain silicone dressing, in order to create that adhesion to the centre or the edges of the centre of the wound. We would then remove the remaining wings one by one in order to get that clear adhesion of the dressing, but at the same time in a sterile aseptic non-touch technique. We'd mark the dressing with an arrow to indicate the direction of the closure of the skin tear, which also gives us a way of identifying how the dressing should be removed. If you're not the next person to change this dressing, then it makes it clear to somebody else how they should be removing it in order to prevent any further trauma. We can also date the dressing so that we can see when it was applied and when it's likely to need to be changed again. You should be observing for any signs of infection that are spreading beyond those margins of the dressing. So are there any signs of redness, swelling, malodor, increased exudate, pain, all things that should present as sort of red flags to us. If that is the case, then you would need to remove your dressing and thoroughly assess your wound and see what was most appropriate course of treatment moving forward. I have some examples here of skin tears, courtesy of the East of England Ambulance Service, who have seen and treated some of these skin tears. So as you can see, you have a wound here that actually is a type 1 skin tear. The first image is initially after the skin tear. Then you can see that the wound has been reapproximated and that skin brought back over to cover that wound bed. You can see the progress in image 3 and how the dressing has been applied with the arrow in situ on the dressing to show the direction of removal. Again, another skin tear from the East of England Ambulance Service on day 1. You can see that actually this is just below 5 centimetres in length, and it looks like quite a nasty skin tear, quite a deep skin tear. But with the same sort of treatment that we've discussed, with cleansing that wound, reapproximating the edges, and then dressing with an appropriate dressing, you can see by day 21 you have a healed skin tear. So that's just a brief overview on skin tears and how we best manage and treat them. And if you have any questions, then please feel free to reach out to your local Coloplast representative. Thank you.